So first, by Dr. Jose, he has already stressed the importance of CDK4/6 inhibitors. My topic first abstract is on real-world evidence of palbociclib. In the real-world scenario, does it really help compared to what we have seen in trials that most 60% patients are of PS0? We hardly see in our day-to-day life that when patients is diagnosed with breast cancer, they are PS0. So in real-world evidence does make a difference. So this trial was designed to evaluate the effectiveness of first-line palbociclib plus AI compared to AI alone in patients with hormone-positive and HER2-negative MBC in real-world in US. A Flatiron Health Analytic database was used, which has around 280 community centers and 25 tertiary institutes. The inclusion criteria of this retrospective analysis was almost like the prospective studies that we have gone through in previous sessions. So most of the patients were more than 18 years of age. Around 2,800 patients were screened, and 1,300 patients had received combination of palbociclib and AI, and 1,500 received only AI. The statistical technique that they have used is stabilized inverse proportionality of treatment weightage and propensity match scoring for primary endpoint of OS and secondary endpoint of PFS. So at baseline, the unadjusted cohort had 1,300 of combination and 1,500 of AI alone. But after SIPTW and propensity score matching, the baseline characteristics were almost matched in most of all the cohorts. Most of the patients, as we see in our daily routine, that 1/3 are upfront metastatic or 1/3 are metastatic after 1 to 5 years, and hardly any patient recurs within 1 year in a hormone-positive cohort. Same thing they found. Many patients were oligometastatic, more than 50% in almost all the cohorts, and number of mets decreased. 2 metastases were in around 20% of the patients, more than 3 were hardly seen in many patients. So the primary endpoint was OS. OS was an unmatched population. In matched population, there was similar OS advantage of adding palbociclib to aromatase inhibitors even in the real world scenario. For forest plot, you can see except for brain metastasis, which is going towards crossing the unity, otherwise for all the subset analysis, and age less than 50 years, otherwise for all the subset, there is benefit of adding palbociclib to first line AI in real world. Even for PFS, which was the secondary endpoint, PFS was, as per the real world evidence, that it increased to around 20 months for the combination compared to AI alone. So in conclusion, this study says that combination of CDK4/6 inhibitor with AI is more effective than AI alone in advanced metastatic setting in first line setting. My second top abstract is maintain trial, which said whether can we switch CDK4/6 inhibitor, continue CDK4/6 inhibitor, but switch the endocrine backbone. So CDK4/6 inhibitor is the standard first line, as my first abstract showed, and ribociclib with ET has shown to improve PFS and OS in phase 3 as first line therapy. But when we stop CDK4/6, there is anti-proliferative effect of CDK4/6 inhibitors is reversed upon discontinuation. So should we continue CDK4/6? This trial was designed for? So most of the patients had progressed on all the patients had progressed on first line ET and CDK4/6 inhibitors, and they were randomized to ribociclib plus switch of endocrine therapy or placebo plus switch of endocrine therapy. Around 60 patients were enrolled in both the arms for primary endpoint of PFS and secondary endpoints of overall response rate and OS. You can see most of the patients, because palbociclib was first approved, so most of the patients had received first line therapy as palbociclib, and some patients had even received ribociclib, and now even in second line they will be continued with ribociclib. So more than 70% of the patients had more than 12 months on CDK4/6 first line CDK4/6 inhibitors. We can see that the PFS of the combination was better at 5.29 months compared to just switching the endocrine therapy, which is 2.76 months, and it was hazard ratio of 0.57. So continuing a CDK4/6 inhibitor even beyond progression can be tried for PFS benefit. The PFS benefit at 6 and 12 months was also maintained. Now, what my previous speaker, Dr. Nandrakant, has said that ESRW, when it is mutant, then obviously the hormone therapy alone does not do great, and so it was even CDK4/6 inhibitors did not do well. The PFS were almost 3 months in both the arms, but when it is ESR1 is wild type, there is definitely benefit of adding a continuing CDK4/6 inhibitor at progression. So conclusion, this is first randomized trial to show the benefit of continuing CDK4/6 inhibitor with and switching endocrine therapy after progression on first-line CDK4/6 inhibitor. There is statistically benefit in PFS, OS data has not been shown till now, and especially those patients who are ESR1 wild type can be continued on CDK4/6 inhibitor. Now my third abstract is again in second-line ER-positive tumors. This time it is for PIK3 mutated patients. So fulvestrant plus Capivasertib versus placebo after relapse or progression on first-line AI in ER-positive MBC. This is the OS and updated PFS data. So approx 55% of ER-positive tumor will have PIK3 pathway mutated, and AKT inhibitor is an effective downstream pathway of PI-K3 AKT P10 pathway, and Capivasertib is an selective inhibitor of AKT 1, 2, 3. So this trial was designed for second line after initial AI. In 2015-18, most of the patients did not had received CDK4/6 inhibitor when this trial was ongoing. So this patient had received first-line AI, first-line endocrine therapy, and then they were randomized to either fulvestrant plus Capivasertib or fulvestrant with placebo for primary endpoint of PFS and secondary endpoint of safety, toxicity, and OS. So in first updated PFS, which is this present abstract, there was consistent benefit of the combination of fulvestrant with Capivasertib compared to fulvestrant plus placebo, which was almost similar to what it was in the previous first analysis of 4.8 and 10.3 months. For OS, which was matured now, the OS data, there is 23 months with continuing of fulvestrant alone versus 29.3 months if we add Capivasertib to the fulvestrant, which is statistically significant with a hazard ratio of 0.66. So the mature data from intention to treat analysis population showed that addition of Capivasertib to fulvestrant improved OS compared to just placebo and fulvestrant. And the PFS and OS data indicate that Capivasertib predominantly benefited the pathway altered subgroup, which I have skipped. Those who had mutation in the AKT pathway, they benefited more. The PFS is 12.8 months compared to just 4.6 months who do not have mutated pathway, and median OS is whooping for 39.8 months versus compared to only 20 months those who were not given any AKT inhibitor. Thank you.